All right, my friends. So we are looking at chapter 9. And you say, wait, Mr. Hess, we've not had our chapter 8 test because, of course, that's coming on Thursday. Why are we doing this now? They all connect, right? These last three chapters, 7, 8, 9, are all dealing with bones. First, we talked about the tissue. Then we learned the actual names of the bones and structures. And now we're looking at more how they work. Because one of the key things with bones are the joints. The joints are the point where two bones come together, right? Whether they're movable or not, because there are some joints that aren't movable. We'll talk about those today. There are branches of medicine that study the movement of joints. Okay? Arthrology, which I've never really heard much about, to be honest with you, but kinesiology is a huge one. I must admit, in my PT schooling, the kinesiology classes I took were some of the funnest classes I took. It's all about the study of movement, how you get movement through your musculoskeletal system. You see that's a combination of two things, right? Muscles and bones together, how you move. So sports science is kinesiology. How you walk. We did 2 whole classes, like literal college classes on how you walk. Not like teaching someone to walk, but analyzing how they walk. What muscles are involved. What angles things have to be at. It's fascinating. I would love to do more research and more interest into this piece. Sir?
You already answered my question, but I was wondering, kinesiology, does that necessarily have to be limited to musculoskeletal?
Oh, sure, no, it's all motion. Yeah. And that's where most of the motion in our body comes from, is from the musculoskeletal system. At least that we really care about as far as studying movement. Josh had a question? Or did I answer? Okay. Yes, oh, sorry, Casey. No, so you have motion that you could consider to be the most efficient with the best posture, but there's really not a right way to walk. Have you been ever, you can identify people just by how they walk, right? Like if they're walking away from you, you can still tell who it is. Apparently I have a very distinct walk, my wife tells me. Okay, sure, very good. All right? Just look at walk like me, right? But we all have distinct ways of walking. So, but there is no like perfect right way to do it now. Uh-huh. Shh. Mm-hmm. No, I got you. And again, so there are always things that you can correct or things that you can, and when I say correct, it means it sounds like there is a right way of doing it. There are ways that are most efficient, that can cause the least amount of problems. So that may be something that could give you issues in the future, sure, certainly. What is perfect posture? If you think about a nice straight line, if you look from the side, between ears and shoulders and hips. That's what you're looking for. You got little curves in your neck, little curves in your spine, in your lower back. But that nice straight piece versus, like this, like so much of a stand. Yeah. All right, let's keep rolling here. Joints all have names, and I don't mean just knees or elbows or hips. Every joint has a name, and most often we just name them by the name of the bones that are involved. So the radio-ulnar bone, joint, would be the joint between what two bones? Radius and the ulna. Okay.
That's different than
So this is different than the interosseous membrane that runs between those two bones. Yes, you are correct. This is the actual place where those two bones touch. And it happens in 2 places, right? One proximal and one distal. Yeah. We have 4 major joint categories: bony joints, fibrous joints, cartilaginous joints, and synovial joints. We'll go into much more detail about those guys. Let's go to bony joints first. Bony joints are called synostis. synostosis. Synostosis. There's a number of these kind of funky words in this chapter. Now, there are nice pronunciations of these words, just so you know. I'm on page 275. Synostosis. Synostosis. And that's an immovable joint. Two bones are together, and there is no gap, or there was a gap, and that gap ossifies. It turns into bone, so that now these two bones are one. Okay? The example I gave you here is the left and right frontal bones. It can also be the left and right mandible bones in an infant. Okay? That these bones actually are totally separated. Here's the frontal bones right here. Right? Here's the mandible. And in the infant, there's actually a gap. There are two separate bones that fuse together. Okay? So they are no longer two separate. They are now one bone. Okay, there's osseous fusion. In adults, the joint between the first rib and the sternum will become ossified down the road. Okay, we classify it as something else most of the time, but it can become a bony joint as well. Sir?
Is there a condition where that frontal bone doesn't ossify?
You guys always ask me, are there these conditions? I would say yes. I don't know of any, but I'm sure there would be a problem with that. Sure. That makes sense. Yeah. I don't know the name of it or anything, though.
So, if they become into bone, then later is it just not considered?
No, they're just fused together. There is a tiny line that you can sometimes make out where the two have come together. So yes, we count it just as one bone. We just call this the frontal bone and the mandible, right, on adults. But it was two pieces that came together.
What cells the fibers actually? What cells? Or was it just the entire piece?
No, it's just the entire outside. So it's going to be the hard bone. Why am I blanking on the name? Yes, the hard bone, the outside of the bone, not the inside. Yeah, that will come together. No. It just becomes one. It just becomes one. Yep. They're just fusing together. Okay. Next, we've got fibrous joints. Fibrous joints. These are where we have two bones that come together, and they're bound by collagen fibers that penetrate into the two bones and join them together. And there are three types of these fibrous joints. We've got sutures, and again, the fibrous joints are called synarthrosis, or synarthroses is the plural of them. So we have sutures, we have gomphosis, and we have syndesmosis. Let's look at these different ones. The sutures you've seen, right? You've all spent tons of time now looking at the different sutures. Where are they found at? The skull, right? Classic place for these kind of fibrous joints. Okay? And there are actually names for specific types of these sutures. You don't have to know them, but some of them have these wavy interlocking lines, like the coronal and sagittal and lambdoid sutures. There are what they call squamous sutures, where there's overlapping edges in the temporal and parietal bones. And there's also these plain sutures, like the palatine process of the maxilla, where they're just straight two things coming together. You don't have to know those. I just want to make sure you understand that sutures are mostly immobile. They don't really move. They were present to allow a baby's head to move. That's what those fontanelles are for. Those fontanelles are the open areas in the infant skull. It allows these bones to shift and change shapes so that as the baby comes out of the birth canal, it can actually not be this round, hard piece. It can actually give and have some movement to it. Does that make sense? That's the point behind those fontanelles. We'll talk a little more about that tomorrow. But those bones then fuse together in these sutures.
Does it matter what the shape of the bone is when it fuses? Right now I'm thinking as a jigsaw puzzle where a piece fits perfectly. But is it necessarily that way?
That's kind of what the serrate sutures are. They look more like, and again, if you look at those, again, think of that nice coronal suture or the lambdoid suture. It looks almost like a puzzle that's kind of fit together. Yeah, that's what I would call those. those kind of pieces. They're kind of the wavy, interlocking kind of piece. Here's a close-up picture of that. By the way, what suture is this that runs straight down here? Sagittal suture. What about this one? Coronal. How about back here? Lambdoid. Good. Excellent. All right. Our next type of fibrous joint is this gomphosis. And this is basically just the attachment of a tooth to the bone. The teeth are not actually bones. They're kind of their own special little something. Okay? But this joint between them, we're calling it a joint, even though it's not two bones together. It's a tooth and the mandible or the maxilla, right? And that's held in place by this periodontal ligament. That there are collagen fibers that attach that tooth to the jawbone and allows the tooth to actually move just a little bit. Not a much, but a little bit while you're chewing. It's not completely, firmly, tightly stable. And you know that there can be movement there because I know many of you have had movement done to your teeth. What do we call that? Braces, right? That if we just add some pressure over time, the teeth will move. Okay? And if you don't wear your retainer consistently, the teeth will move back. Does that make sense? Cool. Has anybody actually ever had a tooth removed before? Yeah. Yeah, it's craziness. I had one of my teeth out not even a year ago. I guess it's sitting on my desk. I could have brought it in here for you. You can see it. But it was the craziest thing. It was one of my wisdom teeth. And it was like the easiest thing. They numbed this all up, right? And this dentist guy comes in and he just like has these pliers and he like literally hammered a little bit and moved it and then okay, that'll be $700. And off he went. Yeah, no, it's not cheap. It's not cheap. It's not cheap. Sir. Sorry, say again? No, you don't have to. It's just sometimes our jaws are too small for it.
Well, mine were they were never coming out.
Sure. Or sometimes they are growing sideways. I actually have one down here that's growing literally sideways, but right now it's not a problem, so. Yeah, or they don't come out or yeah. Into tusks? Nah.
Not like super long, but just like maybe like a...
No, there's not enough space there for them. Yeah. All right, and the last type of our fibrous joints are the syndesmosis. And these are where we have these fibrous joints where two bones are bound by long collagen fibers. Nathan, you mentioned this earlier. These are the interosseous membranes that form between the radius and the ulna. And there's also one between the tibia and fibula as well. If you've heard of somebody having a high ankle sprain, that's what they're talking about. They're actually separating some of these ligaments that hold the bottom of the tibia and fibula together. Okay? So you're not actually dealing with the joints of the ankle. So in other words, there are ligaments that hold the talus onto the tibia and the fibula. We're talking about these guys up here further is technically what we mean by a high ankle sprain. From fibrous joints, we go to cartilaginous joints. So we had bony first, right? Bone, we're actually together, and then fibrous, and now we're into cartilaginous. Okay? And these, again, are the three types of joints that we normally don't think of. When I think of a joint, you think of a hip or a knee or a shoulder, right? We'll get to those in a second. This is the last of those non-normal, in quotes, kind of joints. Cartilaginous joints, we've got two. And again, these are just simply two bones that are linked by cartilage. The first is called a synchondrosis. Synchondrosis. And again, this is where we have bones that are bound by hyaline cartilage. Okay? There are certainly some temporary joints that are set up in the bones between the epiphysis and the diaphysis. Right? Because remember, it's cartilage that's laid down there that turns into bone. Remember that from chapter 7? And then also this attachment of the first rib onto the sternum. So this guy right up here, they zoomed in. Here's the first rib underneath the clavicle where it attaches onto the sternum. That is a cartilaginous joint. And again, it allows for more movement than would be if that was a fibrous joint or even an osseous joint. And we know there's lots of hyaline cartilage here between the actual ribs and the sternum, right? Those would be the same. These would be a cartilaginous joint. Does that make sense? And again, the point is this allows more movement. We're getting into more and more movement as we're going along here. And the last of these cartilaginous joints is a symphysis. You know a symphysis, right? The pubic symphysis, or the symphysis pubis, right? Where the two halves of the pelvis are attached together. Again, by this nice cartilaginous tissue. In this case, it's fibrocartilage instead of hyaline cartilage. The intervertebral discs between the vertebrae of the spine, those are also cartilaginous joints. Little movement, it's not a huge amount of movement, but when you add all the different segments, all 20-some segments together, you get more movement of the spine than you would otherwise. Right, sure, there's enough stability there so that it won't just fall over, but movement to still allow you to actually be able to move. Yeah. Okay, sir. Are all your bones connected? Except for one. Well, okay, two. Well, okay, three. Your hyoid, right? It's not no joints. Your patella, it lays on top of your femur. But so I guess there is a joint there, but it really is not a significant one. And then there's a little tiny piece here on your wrist that you can feel on the very end there that can be disconnected. Sometimes it's actually connected to the little pisiform bone there, but not always. And those are the only three that I can think of off the top of my head. Well, yeah, they kind of still attach to the spine, though. Yeah, they don't attach to the front sternum, but they do attach to the spine. Because it's literally surrounded by the tendon of the quadricep. It literally goes, encircles the entire thing, and then becomes the patellar ligament from there down to your tibial tuberosity. We'll talk much more about that. Okay, so that's it as far as the first three types of joints. The main type of joint that we want to spend some time with today is called a synovial joint. A synovial joint is what we would call the normal joints, right? In quotes, normals. Your hips, your knees, your elbows. When you think of a joint, you are more than likely thinking of a synovial joint. And it is a joint in which two bones are separated by a joint cavity. There's actually space between them. They are the most mobile of any joints compared to the other three that we just talked about, the bony joints, the fibrous joints, the cartilaginous joints. Synovials move much more. They're also much more structurally complex, and we'll show you how that structure looks like. Because there's more movement, because there's more complexity, are you comfortable that leads to more dysfunction, more problems? Okay? Just makes sense. If things are moving more, it's more likely to cause problems. And certainly for most of the medical world, these are the joints we deal with the most, right? I rarely ever was dealing with any of the other types of joints. We did deal with some of the fibrous joints in the pelvis, between the sacrum and the pelvis, between the symphysis pubis, certainly some rib pieces, but for the most part, we were dealing with synovial joints.
Are synovial joints, do they tend to be stronger than the other joints that we?
It's a difficult question to answer. Stronger? I don't really think so. I mean, if I put two bones and I literally glue them together with bone, that's pretty darn strong. You know what I mean? Whereas this guy, there's actually space between them. So no, I would say it's much less strong. But it's much more mobile. You know, you're trading the strength, in quotes, for mobility. Yeah. So this is a great picture. This is on page 279. I do want you to be comfortable with this diagram, understanding how these synovial joints work. Because this is just a basic synovial joint, right? This is looking like the joint between two of your phalanges, in this case the proximal and the middle phalange. But this is a normal synovial joint. You've got two bones, and you see there's actually space between them, right? They're not actually next to each other. There's some space there. Let me just finish, I promise. Okay? Inside that space is what we call synovial fluid. there's actually a liquid lubricant that is in this joint. And again, we call it the synovial fluid. This makes the joint slippery. It allows it to move without having a lot of friction there. How is that fluid kept in? There's a capsule, a joint capsule, or the synovial capsule, that holds that fluid in place. And that's the big pieces of the synovial joint. Question? Right, you're moving the bone through more motion than possible. When you do that, it does release these little gas bubbles that give you this audible click. It can also be that there's a tendon moving. It's not always just the gas pieces, but yes, you're correct. Yeah. Can you see that on the end of these bones, where the two bones come together, there's something called articular cartilage. Okay? This is a cartilage that is put down there, a hyaline cartilage that's on the end of these bones. And again, it just allows them to rub together with as little friction as possible. It gives some cushion there as well. It absorbs some of that synovial fluid. That's why they tell you to warm up before you exercise, because we want to get that fluid warmed, which allows the articular cartilage to absorb it, which allows the joints to move freer.
Oh my goodness, I'm
So this is kind of a little off topic.
Yeah.
How does double jointed?
So double jointed simply, it means that you have more mobility than normal. When we talk about range of motion, I'll come back to that if you don't mind me waiting, because it'll make much more sense when we talk about it then. Sir?
So that synovial fluid, it's kind of like oil.
It's exactly like an oil. Right. Right. It has more the consistency of like raw egg whites, but it's very viscous, very slippery. Like it moves, there's almost zero friction between those two bones, which is a pretty impressive thing. They're getting little cavitations, little air bubbles that are forming inside that fluid. Yes, you're correct.
So they're also in the fingers.
Yeah, between all these joints in your fingers and in your wrist, yeah, these are all synovial joints. No, the trouble with cracking your knuckles, I think we talked about this before even, is that you are moving them through more of a motion than they're supposed to. So for example, I can only bend my finger back this far, right? But if I want to crack it, I push it back further than that. Well, I already cracked that one, sorry. And it causes that. So you with me? I go from this amount of motion to this amount of motion, right? Sure, because I'm stretching that joint capsule around it, right? And as that gets stretched out, it leads to more mobility. More mobility means I can break down. We'll talk much more about this because there's a whole section on arthritis. But I can break down that articular cartilage and stretch out that capsule that holds it. It's not much. No. They're just doing it usually on a larger range of motion and with more weight into it.
So they're both the same.
Yeah. Mm-hmm.
So that's going to.
Again, being a gymnast is not a bad thing, but you are getting hyper flexible. You are moving it through more range of motion than they're supposed to move, right? Nobody can just naturally put their leg up back behind their head. Ooh, I kick over the thing, right? Nobody can just naturally do that, right? It's more motion than you need.
What is that range of motion? What determines how much range of motion?
The joint itself. We'll talk. There's a whole section on range of motion. So if you don't mind, we'll wait until we get to that. Yeah. Mm-hmm. Sure. I don't see why not. Yeah, there are things we can do to help that even now to grow back better with stem cell treatments. But it's not perfect by any means. But no, I could certainly see that happening. Yeah. Good. You don't have to know that there's two different types of capsules. There's an outer fibrous capsule and an inner synovial membrane. Just understanding there is a capsule that covers it. A few of the synovial joints have a fibrocartilage that grows inward into the joint. And it basically forms what we call an articular disc, which is a bit of a pad between the bones. So in your TMJ, your temporal mandibular joint, this dot right here, okay? That would be TMJ syndrome, but the actual joint is just called the TMJ. This guy has a disc between the two bones, okay? And it actually moves as you open and close your mouth. That clicking you may hear is that bone getting caught on that disc. In your knee, you have meniscus, and I promise, Marlon, I get your question. You have meniscus. Meniscus literally means little moon, because they look like little half moons. When we talk about the knee, you'll see them. And they guide the motion of the femur on the tibia as it moves. As the tibia moves, these menisci guide that motion. Your question, Marlon? No, it's always being produced. But if you are dehydrated, that can be something that is affected. Sure. Mm-hmm. Yeah. If you're what?
If your jaw cracks.
Okay. It can be. It can be irritating. Sure. Yeah. It doesn't mean if it cracks you're going to die, but no, it can be a problem.
So like if you were dehydrated, would you be more prone to injury?
Sure. Yeah. Listen to how these professional athletes talk about how much water they drink and how important hydration is for them. It's huge. It's a huge thing. Huge thing. All right, a couple of accessory structures and I'm done. We've already talked about a number of these guys. The tendon is collagenous tissue or, right, fibrous tissue that is attaching a muscle to a bone, okay? Most of the little sticky uppy things that we're learning on the bones, those are where muscles attach to bones. When we get to the next couple of seconds, when we get to the next unit on the muscular system, we'll talk all about the different muscles that attach on those different places. Greater trochanter, lesser trochanter on your hip, right, in your femur, big muscles attached there. Deltoid tuberosity on your humerus, right? Radial tuberosity on the radius. The scapula, the coronoid process, these are all places where bones attach. On your skull, the styloid process, the mastoid process, these are all places where muscles attach. And that's why I want you to learn them, because it'll make more sense when we do the muscles. Because basically, those two structures move together. The two ends of the muscle move together, and that tells you the motion of that muscle. Sir?
When those muscles are attached, are they like attaching to the surface, or are they like digging?
There's actually some digging in that happens, like a fusion between that tendon and the bone itself. Yeah. It's a very strong piece. Ligaments are the same kind of tissue, but it's just attaching two bones together. And what I love about this new textbook, my old textbook had nothing. The last section of this chapter talks about some of these individual joints, the knee, the hip, the elbow, the TMJ, and you actually see the ligaments. My old textbook didn't even talk at all about ligaments, which was a big problem, I thought. So I'm looking forward to talking about that with you. The bursa are little sacs that have synovial fluid in them. And basically they're little pads, little friction pads. Have you ever, like the ladies, when you put those little pads in the back of your high-heeled shoes so your feet don't slip, okay? That's what basically a bursa is. It's so that as a tendon is rubbing over a bone or over a muscle, there's not any problems there. Does that make sense? So the example they give is in your hand here. There are tons of little bursa between the muscle and the tendons because there's not a whole lot of tissue right here, right? But you got a, excuse me, a lot of parts that are moving. And so these bursa help give that, that protection. Has anybody ever banged their elbow, like the very point of their elbow on a table or something, and then it swells up really big? Okay? There's actually, don't try it. there's a bursa that is right sitting on the very end of your elbow here that allows this skin to move over the bone. Okay, because all day long as you bend and move, that skin is rubbing on that bone. And the bursa provides this pad to allow it to do that. But if you hit it just right, you can rupture that bursa and it'll swell up very large. Okay? It will go back to normal. Sure, yeah, certainly, as that fluid drains out of it. But basically you burst that bursa. Okay? There's one more thing. Oh, the sheaths. A tendon sheath is basically just a bursa that's wrapped around the tendon. Okay? We already talked about exercise with it. I'm skipping this whole section on levers or levers. Okay? It's not on your study guide. You don't have to know it. Let me just spend a brief moment talking you through. Levers are basically how things work. You physics folks will talk more about this in the future. There are 3 different classes. A first class, you always have effort and fulcrum and resistance. Fulcrum is the pivot point of a lever. And we break them into classes based upon where the effort, resistance, and fulcrum are. Okay? You don't have to know these pieces. But an example of your first class lever is your jaw here. The fulcrum, I'm sorry, not the jaw, the atlanto-occipital joint. Atlanto being atlas, occipital being the occipital bone, right? Where these guys meet together. Because the effort is to the right of the fulcrum and the resistance to the left. This is why when you're nodding off in class, right, what happens to your head? It goes down because there are muscles that are actively holding it up, right? So when you fall asleep, those muscles relax and your head goes down because the resistance is in front of the fulcrum, right? So it's pushing your head downward. Second type of lever would be, a second class lever would be that the effort is on the end, the resistance in the middle, and the fulcrum there. Imagine you were holding a baby on your knee and you're bouncing it up and down, right? The fulcrum is your hip, right? And the effort has to come past that to hold that guy up. Third type of lever is like your biceps, a biceps curl. The resistance is way out here. The fulcrum is way in here. The effort actually is in between those two because the biceps tendon attaches inferior or distally to your elbow. It actually attaches on that radial tuberosity. Okay? Are you comfortable this is much less efficient to do that? Nah, hold on one second. So your textbook talks about the mechanical advantage of these things. So check it out. I'm not going to test you over it, but worth taking a read at. Last piece is range of motion. How do we determine range of motion? This is the amount of motion that a joint can go through. Okay? Your shoulder. Does your shoulder have a lot of range of motion? Sure. Yeah, certainly. Oh, because it has a tiny little socket and a very large ball, right? That allows it to move. The head of the humerus is very large compared to the glenoid, right? So it can move through a lot of different motion. Whereas your hip, right? Your acetabulum is a big, thick socket, right? It doesn't let the head of your femur move nearly as much. Oh, it's a whole complex motion. We really could break it all down. It would make me so happy, but we don't have time. There's a whole bunch of stuff that happens from the humerus to the scapula to your clavicle to your ribs to your spine. All of these things have to move in order for you to lift your arm up like this. A whole sequence of muscles. And literally, this is what kinesiology is, David, is you would be breaking down the motion from all these different muscles, all this range, all these different degrees. It's very exciting, I think, in my humble opinion. What determines that range of motion? Josh, I think you asked this question. Or somebody asked the question about what determines range of motion. Okay, that was Nathan. The actual surface, the articular surfaces will determine it. Okay? So the elbow, where the olecranon fits into the fossa, right? Where that fossa and the olecranon actually meet, that limits the range of motion. It can't go any further than that, right? If you've gotten very tight ligaments or joint capsules around that joint, it limits the range of motion. If you stretch those joint capsules, you have more. That's what a gymnast spends their time doing, right? You get into that split and you just hold it and you keep letting go down, down, down. I can't even come close to doing a split, so I won't even try. Okay? You keep stretching those areas, not just the muscles, you're actually stretching the joints themselves. the joint capsule pieces. And last but not least, the muscles and the tendons. How tight those muscles are, how active they are, will depend on how they can go. Again, my hamstrings are not super flexible. They are pretty tight. Oh boy, that's really tight. Okay? But if we were to keep working, I could get down further. Just simply over the course of a few minutes, I could get more and more range of motion as that muscle stretches out. Right? Does that make sense? So my range of motion initially is less, but as I stretch, it becomes more.
Is there a certain flexibility that's the best for you to have? Because some people are very stiff and some people are very
There are range of motions that they would call normal for each joint. There are degrees that they have. Yes. The easiest way I would say that is the motion that allows you to do what you need to do. Motion that allows the joints to be in positions that you want them to be in to be able to function. But again, there are actual numbers you can look up. Every joint has its own specific range of motion. And that's literally one of the things as a physical therapist, we measure that a ton. The actual motion of a joint. Someone has a knee surgery, right? And they can only bend their knee to 90 degrees. No, we want to get it to like 135 degrees, this angle. Okay? And so we do lots of things to help that motion. We want to get to a full 0 degrees of extension. You actually have a little bit of hyperextension, like -5 or 10 degrees, where your knee actually goes downward. Okay? We want that motion. There's actually a rotation that happens in your knee to make that happen. So we're very concerned about that as therapists. Yeah. Sir?
What causes, so there's people, there's bodyweight bodybuilders, and there's weighted bodybuilders. And
Okay.
you tend to see that people who use full body workouts or bodyweight training tend to be more flexible, even though they're just as bulky as people who use weights. What causes the difference in weight?
They're being purposeful about putting those joints through more of their range of motion. You want to build your biceps really large, you just simply work right here. Okay? You'll get huge biceps, right? But they won't be very functional. They won't be able to do as much. Versus if I'm doing that full range of motion with my biceps, I've got better strength all through it. That's just one example. Carlos.
So you said you could do like the over like negative.
Mm-hmm.
How is that possible if the patella is like
The patella really has no motion in that at all. It's just well, I won't say that. Your quadricep muscle is contracting, and it actually is just moving back. And it's not really 10 is probably too much. 5 degrees, a little bit of hyperextension is okay. I don't know if you've ever seen some of these ladies who like totally lock out their knees backward. Yeah, that's even more extension. Yeah. Okay, I thought we were going to have some time to go through bones. I apologize. I was going to give you more time, but we got through some good pieces here. All right? Again, tomorrow, well, let me just stop this here.